Welcome to the Adaptive Biotechnology sponsored symposium. Today we will be covering the relevance of MRD assessment in the clinical management of multiple myeloma patients. We are joined by Dr. Lanny Kirsch from Adaptive Biotechnologies, Dr. Bruno Paiva from the Universidad de Navarra, and Dr. Karthik Ramasamy from Oxford University Hospitals. Just a few housekeeping things to keep in mind. If you have any questions for our panelists, please submit them through the GoToWebinar control panel, and these will be answered at the end. We will have polls throughout the symposium, so keep an eye on your screen to take part. Lanny, whenever you're ready, you can start your presentation.
It's a pleasure to be able to speak with you today in this virtual session on MRD and myeloma. Again, I'm Lanny Kirsch, Senior Vice President of Translational Medicine at Adaptive Biotechnologies. Adaptive has developed a next generation nucleotide sequencing platform that has been FDA cleared for determination of MRD from the bone marrow of patients with acute lymphoblastic leukemia and multiple myeloma, and is CE marked for use in lymphoid malignancies. During the course of this talk, I may refer to applications outside of these clearances, but that are part of the offering of the laboratory-developed test performed at the Adaptive Laboratory in Seattle, Washington. The topic of today's presentations is the use of the determination of MRD, which stands for measurable or minimal residual disease, in the clinical management of patients with multiple myeloma. Now, this slide may stay on your screens for a while because there are several points that I want to make as you're viewing it. First, the concept of MRD determination is as old as oncology itself. A patient presents with disease, and the size and extent of his or her tumor is assessed. A medical intervention is begun, and the efficacy and success of that intervention is subsequently evaluated. At first, this was done simply by a physical exam. As the tools of medicine developed, bone marrow cells were obtained and stained to reveal their morphology, and the number of aberrant-looking cells were counted. Within the past few decades, conventional flow cytometry, serum paraprotein analyses, and ASO-PCR, which stands for allele-specific oligonucleotide polymerase chain reaction, have been increasingly utilized. Today, more refined techniques have been developed, which allow for a level of accuracy, specificity, standardization, and sensitivity that provide deeper and fuller insight into a patient's disease status. We're often asked, are such refined and sensitive techniques really necessary? Well, they may not be necessary when having to deal with intractable or incurable disease. But fortunately, myeloma has seen a welcome burgeoning of new, highly efficacious therapies, such that a patient with myeloma may now be approached with the goal of disease control or even intent to cure. Thus, today, these highly refined tests are not a luxury, but rather a necessity of appropriate clinical management. And newer technologies are being explored as well. One other thing before I leave this slide. I will next be presenting a few slides on the technology of nucleotide sequence-based approaches for the determination of MRD. Bruno Paiva, who will speak next, is an expert in flow cytometry-based methodologies. There are times when he and I appear together in a session at a meeting and the audience presumes that we will argue the comparative worth of these different methodologies. That is not the purpose of today's session. I greatly admire Bruno. I always learn and benefit from the data that he presents and the perspectives that he shares. He, his teams in Navarra and Salamanca, and the entire Euroflow consortium have provided critically important and highly instructive insights into our understanding of when and how to use MRD determination. Next generation flow cytometry will be here and still be making fundamental contributions 5 years from now. So will next generation sequencing. So will all of these other technologies. These methods have complementary as well as overlapping attributes. Which method or methods you may utilize in the care of your patients will depend on many factors, including clinical details and the specific requirements and capabilities of your own institutions. The important and fundamental point of today's discussion is that you need to use one or another or more than one of these approaches in order to provide the best care for your patients. This need is increasingly being recognized around the world. In addition to all of the clinical trials in which Adaptive Biotechnologies participates, it runs a real-time clinical service, which is seeing an ever-increasing number of physicians send samples for MRD analysis for use in clinical decision-making for their patients. Of the more than 2,300 patients with ALL and myeloma, whose samples were recently assessed, a relatively large number achieved a level of residual disease of less than 1 residual malignant cell per 100,000 total cells at some point during their therapy. This is a tribute to the efficacy of current therapeutic interventions, and again, an underscoring of the need for such refined and sensitive tests in order to understand what is going on within a patient, him or herself. Next generation sequencing hasn't been around as long as flow cytometry, so it may not be as familiar to some of you. It required the bringing together of 3 critical advances in biology and medicine: the understanding of the physical basis of immunological diversity, improvements in the techniques of DNA sequencing that allowed such sequencing to become high throughput and relatively inexpensive, and the bioinformatics sophistication for extracting critical information from very large databases. And the immune database is very, very large. In any one of us, the number of distinct gigabases of DNA comprising all of the lymphocytes that mediate our dynamic immune response far exceeds that of our static germline genome. So how is this enormous diversity in the immune response generated? At a particular phase of development, a lymphocyte undergoes a reaction in which it creates within its genome new DNA sequences. A different lymphocyte, shown in a different color, that has reached the same stage of development, creates an analogous but distinct DNA sequence, and so on and so on. The new sequences in each of these lymphocytes confers on that cell its antigen or pathogen binding specificity. Thus, one cell can recognize cytomegalovirus, another pneumococcus, another hepatitis B, etc. This new DNA sequence is passed on to all clonal progeny of that cell, progeny that will expand if the specifically recognized antigen or pathogen is encountered. However, this expansion can also occur if the clone is malignantly transformed, becoming a leukemia, lymphoma, or myeloma. This newly created DNA is the result of rearrangements of variable, or V segments, diversity, D segments, and joining, J segments, within the T cell receptor alpha, beta, gamma, or delta loci, or immunoglobulin, heavy, or kappa or lambda light chain loci. The site of rejoining of these different segments is called the hypervariable or complementarity determining region 3, CDR3, the region most responsible for the distinct antigen recognition and binding capability of the T cell receptor or immunoglobulin. The assay contains forward primers that recognize each and every V segment for any one of these loci, shown by the arrows on the left, and reverse primers that recognize each and every J segment for that same locus, shown by the arrows on the right. These primers are not patient-specific. They work in samples obtained from every patient, and thus do not require individualization and can be highly standardized as off-the-shelf reagents. All of the different sequences present in the population of lymphocytes that exist in any given sample are amplified and then loaded onto a high-throughput sequencing machine. The number of completely different sequences characterized by their different CDR3 regions roughly corresponds to the number of different B or T cell clones present in the sample. The number of times any particular sequence is seen roughly corresponds to the size of that clone in the sample of interest. Every time the assay is performed, the entire B or T cell repertoire in the given sample is profiled. Thus, in the bone marrow from a healthy individual, numerous sequences representing numerous clones are seen, and no one sequence towers over the rest. In contrast, in a diagnostic sample from a patient with leukemia, lymphoma, or myeloma, again, all of the B or T cells are profiled, but the sequences that reside within the abnormally proliferated clone emerge as dominant over all of the rest of the sequences. These dominant sequences, corresponding to the malignant cell population, are tagged for subsequent tracking in samples obtained during this patient's course of therapy. Let's summarize and add just a few more points about the NGS assay before moving on. Again, the number of sequences roughly corresponds and indicates the number of clones present. The number of times any given sequence is present roughly corresponds to the size of the clone. Amplification bias built into the assay that controls for bias allows for accurate quantification. There is an internal measure of DNA quality. One only needs to see one event in order to make an MRD positive determination. The assay is optimized to routinely interrogate 1 to 5 million cells. It analyzes the entire repertoire with each run. And again, this assay is FDA approved for the detection and monitoring of MRD and myeloma and B-cell ALL using DNA from bone marrow samples. And the clonoSEQ assay B-cell reagent set is CE marked for the detection and monitoring of MRD in B-cell lymphoid malignancies using DNA from blood and bone marrow cells. So what is the sensitivity of this method? In fact, the sensitivity is only a function of the number of cells that are analyzed in the reaction. If, for example, you look at 1 million cells and one of them is the cell of interest, you will see it. If you had a sample of 100 million cells and within it were 100 cells of interest, and you withdrew 1 million cells at a time 100 times, 2/3 of the samples would be positive for the clone of interest, simply reflecting Poisson sampling variation. In contrast, if you were to want to know the sensitivity at the patient level rather than at the sample level, and asked how many bone marrow cells do I need to examine from a patient in order to know with 95% confidence that the level of disease in the bone marrow is greater or lesser than 1 in 1 million, you would need to examine about 1.9 million bone marrow cells. In other words, the limit of detection, or LOD, is 1.9. Many of you will be familiar with this result published by Perot et al. Based on the IFM 2009 clinical trial. Using the NGS-based assay, it was found that the prognosis for patients with MRD at either the pre or post-maintenance period was better for patients with undetectable MRD, defined as less than 1 residual cell per million total nucleated cells, and indicated by the blue line, than it was for patients with MRD in the range between 1 in a million and 1 in 100,000, the red line, which nevertheless conferred a better prognosis than for patients whose MRD level was between 1 in 100,000 and 1 in 10,000, the black line, which was nevertheless better than for patients whose MRD level was greater than 1 in 10,000. Thus, MRD is a continuous variable. The deeper it is, the better the prognosis. A similar conclusion was reached in real-time clinical practice, as illustrated in this study of patients at the University of California, San Francisco, presented by Jeffrey Wolf and Joaquin Martinez-Lopez. In part of this real-world evidence study, in addition, it was shown that the most recent MRD value is the most important, as shown in the right side figure. Patients who are consistently MRD negative, the blue line, or who convert from MRD positive to MRD negative, the red line, have the best prognosis. This obviously looks very promising. And while just a minute ago I said in describing the previous slide that MRD is a continuous variable, data like these are beginning to suggest that for some patients, there may in fact be a level of residual disease below which a patient may be effectively cured. Is there direct evidence of this? Well, the next two examples that I'm going to show are based on the ALL indication and set the stage for what we hope will soon be found to be true in myeloma as well. For children with standard risk ALL who are MRD negative by sequencing at the end of a 1-month intensive chemotherapeutic induction regimen, their overall survival at 8 years of follow-up, shown in the blue line, is 100%. What about children with high-risk ALL? There was already a hint in the literature based on a clinical trial reported by Michael Pulsifer a few years ago that something similar might be true. Recently, another example of real-world data, shown here, seems to support this notion. In a paper by Friend et al. At the end of 2019, children with high-risk ALL who came to bone marrow transplant were studied. Patients who were MRD negative by sequencing, pre-transplant, and then underwent PrEP and subsequent transplant, had a cumulative risk of relapse of 0%, as shown in the black line that runs along the x-axis. These unknown patients, shown in the red line, were simply those patients for whom no samples were sent to the lab of Adaptive Biotechnologies in Seattle. So we don't know their status. Now, what was one of the implications of this study? Well, the pre-transplant PrEP for some of these MRD negative patients included a standard of care total body irradiation, TBI, which, as you can imagine, in a child with additional decades of life expectancy, can lead to numerous severe long-term sequelae. However, many of the treating physicians chose to forego this aggressive course of irradiation for their MRD negative patients. What was the result? For patients who are MRD positive pre-transplant, shown in the left-hand figure, TBI was a very helpful addition. However, those MRD negative patients who did not receive TBI did as well as those who had received it. Thus, a direct, major, and highly impactful therapeutic decision was made based only on the MRD result alone. So what happens when a physician orders an MRD test? A sample is received by the laboratory, processed, and within the next 7 days, the ordering physician receives a report indicating the result. If the sample is from the time of diagnosis, the report indicates how many dominant sequences suitable for subsequent tracking were identified. The follow-up tracking, or MRD report, lists on the front page whether the relevant clone containing the sequence or sequences of interest was seen, and if so, at what level, normalized to an integer number of sequences per million total cells. A graph is also provided that tracks the level of disease over time. Presenting the result as an integer number per million cells allows both doctors and their patients to easily monitor the trend of their disease during their course of therapy. Now, any single point in time value is a measure of tumor burden at that one time point. Looking at the level over time in multiple time points and in multiple samples is a measure of tumor biology, including tumor doubling time. Since the entire B or T cell repertoire is profiled each time a sample is run, additional pages of the report, which I'm not showing here, provide detailed information about the sequences within the malignant clone and all other sequences as well. This test can be run on any sample from which DNA can be extracted, including fresh samples, frozen samples, or formalin-fixed paraffin-embedded samples. So let me review. The strength of this platform all stems from the fact that the immune system is an evolutionary marvel. Immune receptor repertoire profiling has enormous information content. Immunosequencing offers a specific, standardized, and sensitive method for the determination of MRD in lymphoid malignancies. And moving beyond MRD and extending the scope of the platform, it's important to realize that the immune system is a kind of diary, and immune receptor profiling can provide insights that go beyond MRD determination. This final slide underscores this point. Thus, using essentially the same platform, Adaptive Biotechnologies is now profiling the immune system and expanding that capability with the help of the machine learning group from Microsoft to identify patterns of B or T cell repertoires that are diagnostic of a variety of infectious diseases, including SARS-CoV-2. That information is also being used collaboratively with companies like Genentech and Amgen to develop immunotherapeutics for cancer and infectious diseases. I want to thank you all of you who are online, and I will be happy to answer any questions or provide clarification either at the end of this session or sometime in the future. Thank you, and I will now turn the session over to my colleague, Bruno Paiva.
Thank you so much for the very kind words. I must also acknowledge the profound impact that Adaptive as a company and Clonosec had on the assessment of MRD in BCP ALL, obviously myeloma, and even in CLL, those patients treated with immunochemotherapy. And we have greatly learned from the results that have been developed over the past 5, 6, even 7 years? Well, I would really prefer to be in Paris with all of you this morning instead of being here in the laboratory. As you all know, that is not possible. Nevertheless, again, I would like to acknowledge the great work done by the co-chairs of COMy, also the people at Adaptive, and the people beyond that are working to make this symposium possible, Brandcast Health, to make it the most interactive and fruitful to all of you. My role for the next minutes is to talk about the relevance of depth of response and sustained MRD negativity in myeloma. But before I start, I would like to propose some questions to the audience. Can we please see the first question? Now, the first question is, do you evaluate MRD in your practice? Yes or no? Please vote. Well, we have half and half. Half saying 52% saying yes, 48% saying no. Then the second question we have prepared. For those that do not evaluate MRD in your practice, what are the reasons why? And I would ask you to please select all that apply. It is not helpful for treatment decisions. It is too expensive. It is not informative in low risk or high risk myeloma patients, cannot be performed in blood, or other reasons. Please vote. So I believe the majority has claimed that the MRD assessment being too expensive is the reason why MRD is not being evaluated in routine practice. This followed by other reasons, and thirdly, because it is not helpful for treatment decisions. I believe we have a third question. Now, for the other half of you that evaluates MRD in your practice, what are the reasons why? And again, please select all that apply. In clinical trials to learn, to be informed beyond complete remission, because it is the best prognostic factor, because it is an endpoint of treatment, or other reasons. Please vote. Well, again, we have some mixed and therefore interesting results. I believe the majority voted because it is the best prognostic factor in myeloma, followed by the reason of being informed beyond CR, and thirdly as an endpoint of treatment. And I acknowledge that also 1/3 of you is performing MRD in clinical trials to learn. So we'll now move with the presentation. I believe that you are all seeing the slides now. In this slide, you can see patient and disease, excuse me. This slide, you can see patients and disease-related factors with impact on survival. Now we'll focus on those factors, disease-related factors, such as the revised ISS, which is performed in every newly diagnosed myeloma patient. Also, some biomarkers that help you to assess the extent of disease dissemination that are performed at diagnosis, eventually throughout and at the end of treatment, and obviously response to treatment. I think that all of you agree that it is mandatory to assess response to treatment, to identify patients that fail to respond, to also try to predict early relapses after optimal treatment, and conversely, to identify patients with sustained CR. This is clinically relevant. It has been shown throughout the last decade, and the most recent example has been reported by our colleagues at Mayo, showing that the duration of CR in newly diagnosed myeloma is clinically relevant. Those patients with a duration of CR of less than 2 years have, as you can see in the slide, significantly inferior overall survival. And the reason why I'm alluding to this point is because our group, and fortunately many other groups over recent years, have shown that if you combine information on cytogenetic restratification at diagnosis plus patient's MRD status after treatment, both biomarkers are very powerful to identify prospectively those patients at risk of short duration CR. These are patients with high risk cytogenetics at diagnosis and persistent MRD after treatment. Median time to progression is of half a year, and these patients have a dismal survival, median overall survival of 2 years. Beyond using MRD as a tool to identify patients at risk of short duration or unsustained CR, I would go beyond this point and even say that MRD is a biomarker that allows you to identify two different myelomas, MRD positive and MRD negative. And this has been shown in all disease settings, transplant eligible, transplant ineligible, particularly after the advent of the former novel agents, bortezomib, IMiDs, and more recently in relapsed refractory myeloma with the new range of highly effective drugs. Now, in this slide, we can see somehow a paradoxic result. If you look to the outcome of patients with positive MRD, it's quite similar throughout disease settings. However, paradoxically, the outcome of patients with a negative MRD result is somehow superior in transplant ineligible and relapsed refractory as compared to newly diagnosed transplant eligible. Beyond the fact that follow-up is not the same, this slide is illustrating the fact that in patients with transplant eligible myeloma, where MRD started to be analyzed, it was analyzed using low sensitive techniques, whereas in transplant ineligible and in relapsed refractory myeloma, MRD data is more recent and obtained mostly with next generation tools, which are much more powerful in determining MRD, as Lanny acknowledged before. With this slide, I'm also trying to deliver the message that, in my opinion, regarding MRD in myeloma, the best is yet to come, because only now we have highly effective drugs and highly sensitive and specific next generation techniques to monitor MRD. How to define MRD negativity in 2020? I think that the IMWG response criteria is valid and up to date in 2020, and you have two different criteria to define negative MRD in the bone marrow at the cellular level. Sequencing using the Prognostic platform that has been elegantly explained in the previous lecture, or flow MRD negative using HeroFlow SOPs. And I remember back then that this criterion was established for standardized use of these methodologies in clinical trials to learn. But I would also like to acknowledge that beyond clinical trials, whenever these technologies are adopted in routine practice, and I emphasize adopted and not adapted, in routine practice, they also work extremely well. This is an example coming from our colleagues in Tokyo, Japan, using NGS in their routine practice with powerful restratification and high sensitivity being reached. And this is another example coming from our colleagues in Athens, Greece, Dr. Terpus, showing that NGF was perfectly implemented and standardized in their department, again reaching high sensitivity, and the method is being informative in the patients in CR seen at their department, where a negative MRD identifies a subgroup of patients with favorable outcome, whereas persistent MRD allows to identify patients that, despite prolonged CR, have high risk of relapse. Also, in clinical trials to learn, I remember a few years ago that it was postulated that perhaps the role of MRD in defining duration of treatment was such that perhaps patients with negative MRD could stop treatment, whereas those patients with positive MRD would be ideal candidates to prolong treatment. Now, what we have seen recently in 2 different clinical trials from the French and the Spanish groups using next-generation sequencing and flow, but yet highly reproducible results, is the fact that perhaps patients that are benefiting the most from standard maintenance approaches are those with MRD negativity. And in fact, it gives the impression that whenever maintenance is stopped, the risk of relapse among MRD negative slightly increase. By contrast, patients with positive MRD continue to experience poor outcome, and perhaps alternative maintenance strategies are warranted for this subgroup of patients. Now, in light of these results, how can the definition of MRD negativity be improved? In fact, perhaps we should say undetectable MRD instead of negative. It's a matter of limit of detection. I think that the first point is to acknowledge that some patients relapse despite undetectable MRD, in this example by NGF. And interestingly, what we found is that half of these patients displayed extraosseous disease at diagnosis and or at the time of the relapse. And this is emphasizing the fact that for some patients, certainly those with any sign of extramedullary disease at diagnosis, eventually elevated LDH levels, it is important to complement sequencing or flow MRD negative with imaging using PET-CT. This was already acknowledged in the IMWG response criteria and is supported by data, for example, obtained by the French group and investigators at the University of Arkansas. Both groups were able to show that patients with double MRD negativity by flow cytometry here and PET-CT were the ones experiencing the best outcome. By contrast, I would like to call your attention to patients that, despite being in CR, in the data from Arkansas, have positive MRD by flow, also by PET-CT. In other words, it's MRD that is metabolically active, and progression-free survival is, I would say, dismal for a subgroup of patients that achieve CR after total therapy. Another area of improvement is to pay particular attention to the quality of the sample. Please make sure that the sample that is being used for MRD assessment is representative of bone marrow and is not hemodiluted. This is unpublished data by the Spanish myeloma group, in which we have found that among patients with MRD negativity by flow, the blue and the red curves, there are significant differences in progression-free survival between those that we were able to confirm that the sample, the bone marrow sample, was of high quality, the blue curve, or those in which, for example, we have not found B-cell precursors which are present in the marrow and absent in the blood, the red curve, which have inferior PFS. In other words, that was an MRD negative result, but perhaps a bone marrow sample that was extremely hemodiluted and therefore increased the risk of a false negative MRD result. Another concept that I would like to bring is that myeloma is, as you all know, a patchy disease, and there is need for continuous monitoring. We cannot rely on a single MRD assessment, and a negative MRD result must be reproduced and sustained over time. This is just an example out of a growing number of patients in which we are observing that it is perfectly possible to have a negative MRD result, for example, at day 100 after transplant. The sample is of high quality because we are seeing mature plasma cells there. Nevertheless, 2 months after 2 consolidation cycles, we see again persistent MRD. If we hadn't performed another MRD assessment, this patient would have been wrongly classified as MRD negative. Nevertheless, despite all caveats that we continue to acknowledge regarding the field of MRD, it is a very powerful biomarker. There are many examples to sustain what I've just said, but I brought this one because I believe it is very illustrative. This is data, as you all know, from the Halcyon clinical trial. And here I would like to emphasize the progression-free survival of patients with undetectable MRD, which is similar in the control arm VMP and in the experimental arm VMP plus daratumumab, even though in the control arm there was no further treatment after MRD assessment. This is really emphasizing that MRD is so powerful that it doesn't matter the road you take to get an MRD negative result. It just matters that MRD negativity needs to be achieved with next generation techniques, high sensitivity, and ideally sustained over time. This is in fact, in my opinion, the most important criterion from the 2016 IMWG response guidelines, sustained MRD negativity. This is data outside of clinical trials from routine practice showing that patients with sustained MRD negativity for a period of 2 years, the blue curve, have very promising progression-free and overall survival. And this is data that I'm sure all of you are very familiar from Pollux and Castor clinical trials, in other words, relapsed refractory myeloma, where again it was shown that patients with sustained MRD negativity, regardless of the control or the experimental arm, particularly in the Pollux study, these patients have an excellent outcome despite having relapsed refractory myeloma. Now, implementing MRD in routine practice, are there remaining barriers? And I think this is very interesting in light of the responses that were given before during the survey. Cost. Certainly, MRD assessment. Cost may vary according to the technique that you are using for MRD assessment. Nevertheless, in my opinion, I think that costs are very reasonable when we compare to the cost of diagnostic biomarkers such as FISH, or even more recently, targeted sequencing to analyze, for example, the presence of mutations. And I think that the cost of any of these biomarkers cannot be compared to the cost of treatment. Certainly, marrow is an issue. And if we look to the success story of CML, CML is monitored in blood. In 2020, in my opinion, marrow is still the gold standard specimen to evaluate MRD in myeloma. Nevertheless, there is promising data in blood coming from blood MRD assessment. This is data produced by the Euroflow group, reported very recently in blood, in which the Euroflow showed that it is possible to detect in 15% of patients in CR MRD in blood, and this does allow to identify a subset of patients in CR with dismal PFS, only 9 months. It is true that there were 40% of false negative results, in other words, positive in the marrow, negative in the blood. But I think that these results do allow us to envision that perhaps in the next decade, we'll see more and more on how to use blood complementary to the bone marrow. It was acknowledged by the audience. MRD is, in fact, the most relevant prognostic factor in myeloma. It supersedes risk stratification at diagnosis. And if it's the most relevant prognostic factor, I think that already this argument is unquestionable to use MRD in routine practice. Obviously, we all know that MRD negativity or undetectable MRD does not mean cure, and patients will continue to relapse. But again, I insist, please monitor MRD over time, perhaps every year and a half or 2 years for patients with negative MRD, to see MRD kinetics, just as Lanny showed in the report generated by Adaptive, and try to predict MRD reappearances, which has been shown by different groups does predict biological and clinical relapses. Finally, to use MRD as an endpoint of therapy. There are many examples, but perhaps one of the best examples I can share is patients with high-risk myeloma. In this slide, we can see that risk is dynamic and that patients with adverse prognosis, for example, revised ISS3, the green curve, may shift into a favorable one, similar to revised ISS1 or 2, if these patients achieve undetectable MRD. By contrast, I would call your attention to the progression-free survival of patients with revised ISS3 and persistent MRD after VRD induction, transplant, and VRD consolidation, and before maintenance therapy, which is only 1 year. And perhaps this information could be used to modify treatment in these patients. Therefore, I would like to end by really acknowledging the words written a few years ago by Professors Arrousseau and Aveloiseau, saying that MRD negativity was a new endpoint of myeloma therapy. And I would even dare to say that if you are able to demonstrate that such MRD negativity or undetectable MRD is sustained and reproducible over time, then perhaps this is the new endpoint of myeloma therapy. I will stop here and would like to invite my colleague, Dr. Karthik Ramasamy from the University of Oxford, to deliver his presentation.
It's a real pleasure to be part of this MRD Symposium. Thank you, Lanny and Bruno. You gave really good talks. Lanny, you talked about the sequencing technology, and Bruno has really kind of showcased the MRD assessment in myeloma patients. Thank you to the COMy co-chairs for managing, despite this whole COVID cloud hanging upon us, to make this meeting happen. It's really great to see a number of people signed on to this platform. So my role here as a practicing clinician is to try and take you through how do we manage myeloma in the real world practice and how can MRD inform our treatment decisions. In the real world practice, we clinicians know that our patients are often rather different to those represented in clinical trials. They're often more elderly and comorbid patients. We know that the drug reimbursement, even within the Western world, varies and our access levels are considerably different. We know when patients are exposed to these treatment combinations, there are significant drug discontinuations and toxicities that are observed in comparison to what has been reported in trials. The key issue with all of this is the quality of life is often poor, particularly in patients with toxicity, and therefore that drives compliance. And if patients are not kept on therapy, which is key to keep their myeloma under control, we often lose control in these patients. So in the real world, what we clearly are wanting to do as clinicians is we want to start treatment where preferable, we want to stop treatment where preferable, or modify treatment. So to be able to make these real world decisions, we need the right clinical scenarios. And these scenarios are predictable with test results. So we're often reliant on test results in creating the right scenarios where we can make these treatment choices. These tests have to be reliable, and particularly the tests that I'm talking about, such as MRD tests, which clearly shows depth of remission and sustained remission, are key. We need to have tests which we are able to reapply and have the ability to retest patients at different time points, particularly the point that was being made by Bruno about sustained MRD negativity. And this would really help us work with our patients, and get into an agreement and therefore make decisions at the key time points for these patients. So let's take MRD as the test of interest here, and how can that inform treatment decisions? And if we kind of think about MRD, what it clearly suggests is it's going to be more applicable in patients with newly diagnosed multiple myeloma in comparison to relapsed myeloma or relapsed refractory myeloma. Well, why is that? The reason is because higher proportions of patients with newly diagnosed myeloma enter very deep remissions, and we have seen a lot of this data being presented to us in meetings. We also know that the genome becomes more unstable over time in patients as patients relapse, and we have enrichment of high-risk clones in relapsed myeloma patients. And we also know that there is presence of extramedullary disease is high in relapsed refractory myeloma, and therefore just purely solely relying on medullary testing in the MRD techniques that have been discussed to date are rather unpredictable. Over the years, we have managed to control myeloma much better. Since the 1980s, use of autologous stem cell transplant has shown an improved complete remission rates in patients. And since 2000, we have had the ability of using proteasome inhibitors and immunomodulatory drugs for myeloma patients, either on their own or in combination. And we started to see kind of molecular CRs that have been reported since early 2000. And since 2010, we've had a real rush of next generation proteasome inhibitors and IMiDs in combination, and now quadruplet therapies with the addition of monoclonal antibodies to this combination. And therefore, International Myeloma Working Group quite rightly incorporated MRD negativity into the response criteria for patients who have achieved complete response. We also know that complete response rates in myeloma are continually improving with the inclusion of novel agents into the treatment. On your screen, you can see the histogram where we moved from treatments such as VAD, TAL-Dex, Len-Dex, and now in quadruplet combinations. You can see the rise in the light blue bar, which is the overall response rates, and also high quality responses such as VGPR in your orange bar and your light green bar, which is CR. So clearly, this makes MRD more reasonable to consider as a tool to use in our clinical armamentarium in making decisions. The other significant change that has happened in myeloma care is we moved from fixed duration therapy to continuous therapy, both in newly diagnosed setting and in relapsed myeloma. On your left-hand side of the slide, you can see that in transplant ineligible patients, which is where initially we had the lenalidomide dexamethasone combination, which came through after the first study. Now we have through the Alcyone study, the DARA VMP combination, which is given continuously for transplant ineligible patients, and the VRD combination therapy. On your right-hand side, you can see for patients who've had transplant, you have lenalidomide as post-transplant maintenance therapy for these patients. Even in relapsed refractory myeloma patients, you have lenalidomide dexamethasone. You've got a combination of DARA Len-Dex, DARA Velcade-Dex, Ixalen-Dex, Pano-Velcade-Dex, and there are more coming through. And clearly, meta-analysis have shown that significant benefit for newly diagnosed patients receiving continuous therapy, with improvement in PFS, PFS2, and overall survival in patients compared to patients receiving fixed duration therapy. So what I want to do is to start discussing with you, how do we use MRD results as a treatment guide? I want to engage in a very pragmatic discussion using some scenarios and case studies. We all know that the data are currently lacking in the literature regarding the use of MRD in clinical decision-making. There is enough data for us to know that MRD is an important kind of predictive factor, as you've all acknowledged. And depending on the outcomes of these investigations and trials that are ongoing, MRD may have utility in clinical decision-making. And I'm going to highlight 4 contexts, and more may come through in time. The context number 1 that I want to highlight is defining the timing of high-dose therapy in patients who are eligible for high-dose therapy. As we all know, with increasing use of induction therapy, we are seeing quite significant responses in these patients. And in clinical practice, patients are starting to question the value of high-dose therapy. So the current debate and the controversy is about the ideal depth of response required to proceed to stem cell transplant. Currently, we would proceed to stem cell transplant irrespective of the depth of pre-transplant response. So how could potentially MRD assessment help? So if MRD negativity is achieved prior to stem cell transplant, so physicians may consider the benefit of continuing with high-dose therapy or whether not to proceed with high-dose therapy in certain patients. The assessment of MRD before transplant may also highlight the importance of potential graft contamination in these patients and therefore consideration between early high-dose therapy versus delayed high-dose therapy. So all of these have to be explored in clinical trials. I'm just highlighting two trials that came to my attention. One of those is a study of using ELO-KRD in patients. It's a small study, as you can see. And here the question is, in MRD positive patients, can you intervene with ELO-KRD before the maintenance therapy rather than actually going straight on to maintenance therapy? And the second study is the use of daratumumab combination in these patients. So results of these sort of trials will help start to guide us and help build more phase 3 studies, which starts to question whether MRD negativity has to be achieved prior to stem cell transplant for deeper remissions later. The second scenario that I want to discuss with you is determining the need for consolidation or maintenance therapy following stem cell transplant. So clearly there are two approaches that are currently available. One could do a second round of high-dose therapy in patients, particularly with residual disease, clearly of benefit for patients with partial or very good partial response. And also when that is not feasible, use of consolidation blocks of therapy could deepen response in patients. And clearly randomized trials are yet to demonstrate a clear overall survival advantage of this approach. So how could MRD assessment particularly help in this? I'm going to cite a couple of examples followed by the trials. First example is the PRIMA study, which is a parallel study looking at MRD assessment in patients on the STAMINA trial. And clearly the early data that shows that MRD assessment, along with other factors, is predictive of progression-free survival and overall survival, and clearly can help further therapy decisions. The second trial that was presented by Dr. Costa at ASH is the MASTER trial, which is using MRD as a guide to post-transplant consolidation and maintenance therapy. So those patients who are MRD positive go on to get the post-transplant consolidation, and those who are negative just move on to maintenance therapy. So in this particular scenario, there are at least 3 trials that are ongoing that has been brought to my attention. One is the MASTER trial that I've talked about, where they are using a response-adapted use of consolidation. There is a Janssen-sponsored study who are picking up MRD positive patients after frontline transplant and then testing 2 treatment options, lenalidomide versus lenalidomide plus subcutaneous daratumumab. And then there's the SWOG cooperative study who are looking at duration of maintenance therapy using MRD testing, looking at either continue or stop maintenance with lenalidomide or lenalidomide plus daratumumab combination. So clearly these sort of trials will start to look at whether consolidation is required, what type of maintenance may be required to bring patients who are MRD positive negative, and also whether we are able to stop maintenance in patients who are MRD negative. The third setting that I want to explore with you is the non-transplant setting, and this appears to be close to 60 to 70% of newly diagnosed myeloma patients in the Western world. So clearly, we use continuous therapy until disease progression for these patients. So how can potentially MRD assessment help? So MRD assessment may help inform physicians who still want to adopt a fixed duration therapy. So potentially we could have studies describing those patients who have MRD negativity, whether they could benefit from fixed duration therapy. MRD assessment could also be used to determine the length of therapy, particularly for patients on continuous therapy. Unfortunately, there are no current trials that I'm aware of which are exploring this, but I'm sure these would be explored in time. And the last scenario that I want to discuss with you, where use of MRD could be looked at, is defining the timing of treatment intervention. So there's one big dilemma at the moment, particularly at a relapse setting. Do you actually intervene with therapy early on for patients who are relapsing, such as a biochemical relapse, or do you wait until patients get symptomatic relapse? So the debate is still out there, and there are no real trials that are addressing this. Retrospective studies have shown that those patients treated at biochemical relapse do benefit. So how can MRD assessment help this? So patients' MRD status could be assessed as a disease endpoint and identify those who require either further treatment or an alternative treatment intervention. So reappearance of MRD in a patient who is MRD negative could be an early indicator of treatment inadequacy for a subset of patients. And also using sustained MRD negativity as an endpoint, you could start to look at treating patients who have reappearance of MRD negativity and whether they move on to MRD negative and maintain MRD negativity as an endpoint. There are a couple of trials which are looking at this at the moment. The first trial is done by the Polish Myeloma Consortium. They're looking at giving preemptive daratumumab therapy in patients who have MRD reappearance or just biochemical relapse in a relapsed myeloma population. This is using data versus observation therapy as intervention. There is another very small study done in the US looking at, in a post-induction MRD positive patient, giving an alternative intervention of daratumumab plus lenalidomide therapy for about 6 months in these patients and looking at achievement of MRD negativity. So clearly MRD as a tool can be used to define the timing of treatment intervention as well. So I want to talk through 3 case studies with you of patients with potential use of MRD in clinical practice. So first patient is a 62-year-old lady who lives between UK and Italy. She has a performance status of 0. She's a board level executive of a large corporation with a past medical history of inflammatory bowel disease and DVT. She presents with bone pain and fatigue. She was diagnosed in February of 2017 with IgG kappa myeloma, hemoglobin of 92, fracture of L4 vertebra, has a hyperdiploidy on myeloma fissure diagnosis. She has a normal renal function and calcium and an ISS stage 2. So a standard risk disease presentation with ISS stage 2. In February 2017, I started her on VRD treatment, and she has 4 cycles of VRD chemotherapy up until June of 2017. She develops a very good partial response to this therapy, but unfortunately develops a blepharitis due to Velcade therapy needing doxycycline. She also develops grade 1 peripheral neuropathy, and the inflammatory bowel disease symptoms unfortunately got worse during treatment. Thankfully, she achieved a good response, and therefore we moved on to stem cell collection and autologous stem cell transplant with melphalan in June 2017. In the post-transplant state in November 2017, the bone marrow confirmed complete remission, and I did a PET CT scan, which is also negative. As has been done in the IFM study, she had 2 further cycles of VRD consolidation, but unfortunately her IBD symptoms got worse. And in January 2018, she developed a calf vein DVT. And clearly this patient, with the nature of her work, which requires travel and requires fairly high performance, was not keen to start lenalidomide maintenance therapy, which would have been standard of care. So we now have a lady who is fully active and working, who's achieved a bone marrow confirmed CR and PET CT negativity, completed a consolidation, but is unkeen to proceed to maintenance. So I want to do a poll at this point to check what you would all do next in this particular patient. So there are 4 options, as you can see. Option 1, would you choose lenalidomide with some sort of supportive care to address the needs of the patient and move with maintenance? Would you use some sort of an unlicensed low-dose lenalidomide maintenance? Would you start considering an alternative drug therapy for maintenance? Or would you go with treatment-free monitoring for this patient? Please choose your option. Let's look at the results so far. So clearly, about 27% of people on the current call suggest treatment-free monitoring is a good option. About 30% would look at alternative drugs for maintenance, whereas about 44% of people would still prefer to go with lenalidomide maintenance with a degree of support or attenuation. Let's go back to our patient, and I'll give you further information about this particular patient. So, in actual fact, when she had the bone marrow done in November 2017, and this was 3 months after her stem cell transplant, this was actually put through an MRD testing platform by flow cytometry, and she was MRD negative by flow cytometry at a threshold of 10⁻⁻⁵. And this was done 3 months after transplant, and she was PET-CT negative as well. So she's double negative 3 months post-transplant. Now, I want to revisit the same questions that I had put forward to you. Now that you have this additional piece of information, I want to see whether your poll choices would change. So again, the same 4 choices: len with supportive care, low-dose lenalidomide, alternative drugs for maintenance, or treatment-free monitoring. I want to see whether this new information does change your treatment option. Please poll now. Okay, let's look at the results. Very interesting. Clearly, a vast majority of you, because you've already polled previously when Bruno was talking, clearly believe MRD is a very important prognostic factor. And therefore, because of the nature of the patient in front of you, and the patient is unkeen to proceed with maintenance, with the ability to have this new information, a lot of you are comfortable moving towards treatment-free monitoring. Let's look at a second case, and this time we'll look at a patient. So in my patient, we just discussed, I did the treatment-free monitoring. Clearly, she was angling for that, but unfortunately, she's still dodging another bone marrow. I'd quite like to recheck that she's sustained MRD negative, but she's not managed to turn up to clinic to have that done. So this time round, I'm going to present you with a newly diagnosed transplant ineligible myeloma patient. So 83-year-old man with a performance status of 2, who's an ex-policeman with a history of ischemic heart disease and type 2 diabetes mellitus, presents with back pain. This was close to about a year ago in March 2019. It was an IgA kappa myeloma with a hemoglobin of 113, L2 to L4 fracture, gain of 1q21, which is seen in 40% of myeloma patients, normal renal function and calcium, and ISS stage 1. So the treatment this 83-year-old man received was a combination that was shown in Alcyone trial to be better than VMP, which is DARA VMP. It's a 1-year treatment program. He starts the treatment in March of 2019. In June of 2019, he develops a grade 1 neuropathy, and therefore I had to attenuate his Velcade dose. By October 2019, he had already achieved a complete remission. But between June and October of 2019, this 83-year-old man had 2 hospital admissions with pyrexia and was diagnosed with lower respiratory tract infection. By December 2019, he had an episode of cardiac event, NSTEMI, which was treated with medical therapy and discharged. At the end of his treatment in February 2020, when I say the end, that's the end of the DVMP combination. He's waiting his daratumumab monotherapy sequence of treatment. He had a further episode of lower respiratory tract infection and was admitted to hospital. Now, how should we care for this patient? Should we? Let's poll again. 4 options for you. Should we go with daratumumab maintenance treatment, as is how the treatment protocol is? Should we go with daratumumab maintenance with some additional supportive care, such as intravenous immunoglobulins and antibiotics because of the frequent lower respiratory tract infection? Would you think of alternative drugs for maintenance for this gentleman? Or would you think about treatment-free monitoring? Let's poll now. Let's look at your results. So clearly, only about 13% of you think that daratumumab maintenance without any supportive care is an option, but a vast majority of you think that we should continue to proceed with daratumumab with supportive care and IVIG. Some of you would think, about 18% of you would think an alternative drug for maintenance should be considered at this time, because obviously use of daratumumab does increase the risk of respiratory infections, as has been shown in trials. And about 27%, a quarter of you would think treatment-free monitoring is appropriate. Again, let me go back to the case and give you further information this time. And as you would have guessed, the information that I'm giving you is a bone marrow test that I performed in February of 2020. And the bone marrow shows MRD negativity by flow cytometry at a threshold of 10⁻⁻⁵. So we now have a man who's aged a year further. He's now 84. He's had at least 3 hospital admissions with lower respiratory tract infection and 1 further episode of a cardiac event. He's completed the DVMP combination. He's MRD negative. Now I want to go back and see the poll options again and see whether you would stick with your previous treatment option. Vast majority of you picked either 1 or 2. Let's re-poll now and see whether you would move towards treatment-free monitoring. Let's look at the poll results. Unsurprisingly, because of the predictive factor of MRD testing, and clearly Bruno showed that those patients who achieved MRD negative in comparison between DVMP versus VMP, despite not being on dara maintenance following the VMP, continue to enjoy the same level of progression-free survival as patients on DVMP arm, and therefore moving towards treatment-free monitoring is entirely appropriate. Let me go back to my patient, and clearly, as most of you have suggested, what I did for my patient is to go back to treatment-free monitoring rather than continuing with the daratumumab therapy for this patient. So I want to explore a relapsed myeloma patient with you this time. And this time it's a 69-year-old lady with a performance status of 1, who's a retired lecturer here in the university with no significant past medical history at all, presented with bone pain and fatigue. This was in May of 2017. She had IgG kappa myeloma, had a T8 vertebral fracture, and this time on the myeloma fish on the bone marrow showed deletion 17p in 33% of plasma cells. She in fact had normal renal function and a raised calcium and ISS of 2 at diagnosis. As you would expect, we gave the standard frontline therapy of VTD chemotherapy back in May 2017 to very good partial response. She also had grade 1 peripheral neuropathy. In November of 2017, we moved on to stem cell collection and an autologous stem cell transplant with high-dose melphalan. In the post-transplant scenario in March 2018, we performed the bone marrow and confirmed a complete remission, and PET-CT was performed and was negative. She started lenalidomide maintenance therapy. But unfortunately, about a year later, as would be expected in someone who has a high-risk disease with deletion 17p, she relapsed with a paraprotein of 8 grams per liter, and I performed a marrow again, and this time it showed that the bone marrow had enriched itself with more deletion 17p cells in about 55% of the cells that were assessed by FISH. We started daratumumab, Velcade, and dexamethasone therapy for this patient. So in December of 2019, she had achieved a serological CR. The paraprotein had completely disappeared. So at this point in time, in the natural sequence of DVD therapy, we would move on to daratumumab monotherapy on a 4-weekly basis. So again, I want to invoke your opinion as to what you would do for this patient. Let's look at the choices. Would you be happy to proceed with that daratumumab monotherapy? Would you try and continue with DVD as it's been well tolerated and we've got a patient who's got high-risk disease? Would you switch to something alternative at this point? Or would you think about treatment-free monitoring for this patient? Let's poll now. Let's look at the results. So close to a third of you would be happy to proceed with daratumumab monotherapy. About half of you who responded would prefer to continue with DVD as tolerated because she's got high-risk disease. A small proportion of you would consider either alternative therapy or treatment-free monitoring. Let me go back to the patient and then give you an additional piece of information. At the time, serologically, she was in complete response. We had performed a bone marrow, and the bone marrow was MRD positive by flow cytometry at 10⁻⁻⁵. So this lady has completed the DVD combination therapy. She has high-risk disease. She's in serological CR, but she's MRD positive at 10⁻⁻⁵ by flow. Let's go back to the poll again and see whether you would think differently. So the options are, would you give daratumumab monotherapy as per the usual sequence? Would you continue DVD as tolerated? Would you switch to something alternative? Or would you do treatment-free monitoring? Please poll again now. Let's look at the results. Clearly, a proportion of you would switch to alternative therapy because you don't like the look of the fact that she's still MRD positive. But clearly, some of you have moved from just doing daratumumab monotherapy to continue DVD as tolerated because as a triplet combination, it is probably more effective and potentially could even achieve MRD negativity in this particular patient. So clearly, as we can see, use of MRD positive tests also guides decision making in a patient who's achieved a complete response. And in this particular patient, as most of you have indicated, what I've done is breaking tradition and not stopping the DVD combination. I've moved on with DVD combination in the hope that I would retest again in a few months' time to see if she's MRD negative. So clearly through these case studies, what we've explored is how we can use MRD to guide some of our clinical decision making pragmatically, although we need clinical trials to clearly guide us. It's important before I finish, I highlight that imaging MRD negativity is also key. Myeloma is a patchy disease, and adding imaging to bone marrow MRD negativity, the so-called double negativity, is definitely better in comparison to one methodology alone. When would you test for MRD negativity? Serologically, if you achieve VGPR or better, I would say it's probably the right time to test. And the reason for that is we now have quadruplet treatments that we're using, and we're also having CAR T-cell treatments, and they induce significant reduction in plasma cell burden, considerably even before the paraprotein were to decay, such as an IgG, which is the paraprotein of interest in 60% of our myeloma patients. As Bruno indicated, sustained MRD negativity is critically important and will probably become the new standard as outcome measure in trials in the future. And as has been discussed both by Bruno as well as Lanny, tracking MRD in peripheral blood will definitely improve the convenience and ability, and possibly even improve the take-up of testing, as most of you polled when Bruno put out the call as to why some people are not using MRD testing on a regular basis. My final thoughts are treatment paradigms have changed considerably in myeloma over the years, and therefore the treatment goals. MRD testing has given us the ability to categorize a group of patients who clearly have a higher depth of response, which is linked to improved clinical outcomes. Access to MRD information can guide care in patients, particularly those in routine care, where it's really challenging to manage patients with comorbidities, frailty, and where access to medications is difficult. Using MRD information to modify therapy, such as escalate, switch, or discontinue, are key questions currently in the cooperative group studies. And using MRD information as a guide to treatment pathway, as in other hematological malignancies such as ALL and CML, I would say will become standard of care in myeloma. I thank you for listening, and I thank Brandcast for helping us able to beam into your living rooms and studies from our own study rooms. Thank you very much, and we'll now move on to Q&A.
Thank you very much. As just mentioned, we will move into a panel Q&A, so just give me a moment. Okay, great. We do have quite a lot of questions, so let's see what we can do. We will try to go through themes. So I think these questions actually are for the whole panel. Let's start with, when should we really change or discontinue maintenance? Who would like to answer this one?
So maybe I can take that question. So how and when to use MRD to guide a stroke discontinue maintenance therapy? So clearly, as has been demonstrated in my first case, this lady had her MRD test 3 months after her stem cell transplant. That appears to be a good point to look at MRD negativity in patients, and that is often the point when we would start maintenance therapy. So that would probably be the basic standard. That's when we would use it. Clearly, in patients, what I would say is we should probably consider repeating the MRD test. And in my particular patient, I have failed to do so at this point, but obviously either 6-monthly or annual testing may be something that we should consider. Most of these patients, if they were to embark on maintenance therapy, would clearly have monthly blood tests if they're on treatment, and therefore you can look at their serological performance on a monthly basis. But using further MRD tests on a 6-monthly to an annual basis, I would say is appropriate. As to whether we would discontinue maintenance based on MRD negativity, well, those are the questions that are being addressed in clinical trials. And certainly, as kind of Bruno pointed out, the duration of maintenance appears to be critical, and it's coming through in some of the studies. So I think it's be too early to kind of start to talk about when you would discontinue, but certainly patients who are in sustained MRD negativity for a considerably long period of time are the ones we would start to consider that. Bruno, do you want to add anything to that?
Yes, well, I'd like to echo what you said. I fully agree, and just add a little bit of information, which is to perhaps change terminology, and instead of considering discontinuation, something like treatment-free period with active monitoring. As you also acknowledged, Karthik, I can share that in ongoing clinical trials in which we are participating, that in some of those patients, in fact, in most, with the exception of extramedullary relapses, in many of the patients that relapsed despite an MRD negative result at the beginning of maintenance, and then relapsed once maintenance was stopped per a treatment protocol after 2 years. In many of those, we did saw MRD reappearance before the clinical progression. So whether this can be used to establish treatment-free periods, and then initiate early intervention when MRD reappears, that's a different debate. But perhaps this can be more attractive than complete treatment discontinuation.
Good point. Very good point.
That is great. Thank you so much, both of you. We actually answered a few of the questions that the audience had. I'm just going to pass on to this other one, which is slightly related, but a different nuance. Would you like to respond to this one as well?
Yeah, so to stop maintenance, would you use just MRD status or MRD status plus cytogenetics? In actual fact, I was going to ask you this question, Bruno. Clearly, in one of your slides, I think the two key predictive factors is the MRD status and the high risk nature of the myeloma, which is key. So I guess going back to the previous theme of discussion, if we start to think about treatment-free monitoring rather than the start-stop maintenance, would we start to consider that those patients who are MRD positive, plus or minus high risk fish, would our approach to monitoring in that patient population be very different to those who are standard risk and MRD negative?
Well, let me share my vision about this point, which is a very important one. All studies have, I believe all studies, if not all, certainly the majority, have shown the complementary value, for example, in logistic regression, cytogenetics plus depth of response, particularly MRD assessment. However, I believe that the complementary value is mostly confined, particularly now with the more sensitive next generation techniques, confined to the MRD positive population, where cytogenetics, classic standard versus high risk definition, really allow to stratify two completely different subgroup of patients with persistent MRD, those with standard and high risk. And high risk really have poor progression, free and overall survival. Now, what I would like to see confirmed in future studies is the fact that using next generation techniques, people are able to show that those achieving an undetectable MRD result have the same outcome regardless of cytogenetics. I'm confident that this will be more and more appreciated in ongoing and future studies, but I would also like to emphasize, particularly in routine practice outside of clinical trials, that regarding a patient with high-risk cytogenetics, an MRD negative result must be extra cautious. Because if the technique has not been one of the techniques endorsed by the International Myeloma Working Group, or it has not been reproduced at least twice, or careful attention to the quality of sample, etc., the risk of a false negative MRD result in a patient with high-risk cytogenetics has, I would say, very deep consequences from a clinical point of view, because we do know that if there is MRD there, that patient will have poor outcome as compared to standard risk. So any treatment decisions regarding MRD negative patients with MRD negativity with high risk, I would please ask everyone to be extra careful about the robustness of that MRD negative result.
Lanny, do you want to add anything to that?
No, I think that well stated.
That's great. Thank you, everyone. We did have a lot of questions that I believe have already been answered in terms of when to do MRD testing, and if someone is negative, when to repeat the testing. But I believe that Karthik, you covered that earlier in the questions. So I'll pass on to a slightly more technical. I believe this is directed to you, Bruno. So can MRD determination by sequencing be started if a patient is already in complete remission, or does it require a sample with substantial disease burden to accurately determine myeloma clones of interest? There is a sub-question to that. Can flow cytometry determine MRD without upfront knowing the myeloma clones of interest? Or in other words, can measuring MRD by flow be started at any time in disease state?
Well, obviously, I will leave the first question to Lanny, as he's the expert in next generation sequencing. Regarding flow, it is true, you can determine MRD by flow regardless of information at diagnosis. or at baseline if a relapsed refractory patient. This being said, knowing the information up front will always be helpful, but on the other hand, please don't focus, for those that are performing MRD by flow, please don't focus only on the aberrant phenotypes identified at baseline. Obviously, not to the extent that we see, for example, in AML, but also in myeloma, some cases do show phenotypic shifts from diagnosis to treatment. Therefore, information at diagnosis is helpful. It is not mandatory to perform MRD assessment, and at any time you perform MRD by flow, always focus on differences from normal aberrant phenotypes, regardless of the phenotype that was identified at baseline.
And so I'll say first, with regard to sequencing, a high tumor burden sample is required so that you can identify dominant sequences and then tag them for subsequent tracking. However, that initial high tumor burden sample does not have to be fresh. It can be archived. It can be an FFPE bone marrow aspirate clot. And all of those work quite well in terms of being able to then identify the sequences for tracking. In general, with regard to shifts in phenotype over time, that has been studied for the genotype or for the rearrangements. And for those rearrangements, that is a pretty rare event. Again, there is not, with current therapies, selection in particular against or with regard to the immunoglobulin gene rearrangement. And so in general, that particular rearrangement stays trackable during a course of therapy.
Great, thank you. We are running a little bit over, but we have time for one last question. Do you have any recommendations or feedback to collect samples for MRD assessment with high quality?
Well, obtain a very, very good bone marrow and get it in time into the lab is probably what I would say. I don't know if Bruno and Lanny have anything more to add.
I mean, I think that, please allow me to, I think that with perhaps a few more years, we may see again some updating of response criteria or response concepts, in which after a negative immunofixation, perhaps the next test performed will be MRD assessment in the marrow, and therefore the first pull will go directly to the laboratory for the MRD assessment. I think that such slight modification in concept of response criteria will certainly improve the quality of some samples that in some laboratories continue to be the second pull for MRD assessment, which increases the chances of hemodilution.
Great, thank you. I think that's probably all the time we have left today. We have received a lot of questions with more specific case studies, so we will discuss this with the speakers to see if we can provide some answers for you. But that is all for us today. So thank you very much for all of the speakers and Adaptive to support this symposium, and the COMy organizers for setting up this virtual meeting. Thank you very much.
And thank you on your part as well. Thank you.